Today I'd like to talk about neuromusculoskeletal medicine. This is an advanced practice specialty in healthcare for doctoral level professionals, for medical doctors, for chiropractors, for naturopathic doctors, for doctors of osteopathy. Now, osteopaths actually have their own neuromusculoskeletal specialty. The specialty I'm referring to is organized or controlled by the International Academy of Neuromusculoskeletal Medicine. And what the heck is this? Medicine. So is that drugs? Well, sure. Medicine. One definition of medicine is drugs. That's how we use it in everyday life. Oh, hand me that medicine. But another definition of medicine is the profession or the act of diagnosis and management of healthcare conditions. That's why we say lifestyle medicine, functional medicine, neuromusculoskeletal medicine. This is diagnosis and management of conditions. So, medicine of the nerves, muscles, and skeletal. The joints. Now, this specialty is a non-surgical specialty, so it's not designed for surgeons, although I think some surgeons would benefit from taking it. There have been other attempts to create a neuromusculoskeletal specialty in the past for medical doctors, but it hasn't really, they haven't succeeded. This particular organization actually evolved from a chiropractic organization. There's an organization for chiropractic orthopedists. Now, they say they changed the name in part because these chiropractic orthopedists were getting, messages and getting referrals for surgery. And no, we're not an orthopedic surgeon. Orthopedics is, doing orthopedic tests. It's evaluation of pathology. So it doesn't necessarily directly mean surgery. So anyway, they changed their name, and they also opened it up to, I mentioned, medical doctors, naturopathic doctors, and doctors of osteopathy. Now, they more recently opened it up to those other professions. So I don't think there's any DOs or NDs in the program, but there are medical doctors, for example, and there are many chiropractors, and they grandfathered in the chiropractic orthopedists from the old organization. They also revamped the training. Before, it was a residency, so the doctor would have to move and start working at this healthcare facility tied to a university. I forget how many years they would have to do that in order to get this specialty. And the specialty would be called a diplomate of the International Academy of Neuromusculoskeletal Medicine. I'm just going to say DIANM. That's easier for me to say. But now they've made it all digital. So it's an all online program. So basically, any doctor can take it from anywhere, and it's an awesome program. As sort of an expert in education, I taught college for 7 years and was even curriculum coordinator. It's a darn good program. And it really does have sort of the latest evidence, the latest information, which is so important. I didn't go through, I have a doctor of chiropractic degree. I didn't go through that long ago. I think I graduated 2019 or something like that. And I went to arguably one of the best schools for someone who wants to be a doctor, a clinician. If there's chiropractors out there who are more traditionalists, who are more technicians, everyone gets the crick cracks. The way I was trained is not, everyone gets exercises, everyone gets reassessments. That's the way I was trained. And chiropractors, I was trained in Oregon, chiropractors are primary care physicians there. So maybe a little bit of a different mindset. So even in that very evidence-based program, which again was so good, and I think better than any other chiropractic school, instead of having these special chiropractic protocols, Gonstead and things like that, we had Journal Club. talking and analyzing research papers. So even in that type of school, some of the diagnoses we were using, lateral epicondylitis, tendonitis, trochanteric bursitis. I then go and take this specialty, and it's like, oh, we've been using the wrong diagnosis all this time. But it takes time for new information to make its way into the schools. You can imagine a doctor who learned 20 years ago doesn't know the new information. And even me, I just had graduated just a couple of years before starting the program. And if my instructor hadn't heard of the information, then I didn't get the information. So it takes time for new information and new evidence to make its way into healthcare. So a specialty like this gets the newest and best information out into the healthcare professionals' hands. And some of this information is really mind-opening. I mentioned trochanteric bursitis. Bursa is a fluid-filled sac or a cushion. Itis implies inflammation, so bursitis. So an MD or even myself hears that and it's like, okay, so an inflamed bursa. So what do you take? Anti-inflammatories? You inject some corticosteroids into that. That's a strong anti-inflammatory. Is that the correct treatment for that? Well, no. It turns out the bursa isn't what's causing the pain most of the time. Most of the time there is fluid in the bursa because it's a cushion. So there's something wrong with the biomechanics that's resulting in more sort of, if you can imagine, I guess you could say wear and tear, things rubbing on each other more, and so the body puts more fluid into the cushion. I'm actually also registered in musculoskeletal sonography, and when I was doing that specialty and doing that training, we called it, they said, okay, don't diagnose a bursitis in your report. Call it bursal distension. There's extra fluid in the bursa. And then that's a sign that you look very carefully at the tendons because it tends to be a tendinopathy, a problem with the tendons. So this new information changes how you treat patients. And in fact, over the past 10 years, there's been many studies that doctors need to stop giving cortisone shots for tendinopathies. Whereas before it was tendonitis. So itis means inflammation. So anti-inflammatory, that's why I should inject. But now we know that leads to worse outcomes. The VA has recognized the importance of this program and actually has all their chiropractors can take this program for free for them because they'll pay. Actually, same thing with the Army. It's like we need this type of training. And that this is true for MDs, true for nurses, true for surgeons, true for chiropractors. It's even if they're taught the correct information, it's such a fire hose. There's a lot of breadth, and then what's retained is, as shallow as a puddle, because you just retain enough to pass the board exam. And here you're being fed better information more slowly as you're working with patients, and it's information that you can put into practice, that day and might change your practice. I thought this information was so important and so awesome that I put it into a book. My book on pain is basically the educational program dumbed down for the general public, which I recommend for anyone with chronic pain. I think it's a useful book. But where am I going with this? Where am I going with all of this? And I want to tell you is that I would seek out these health professionals. Now, it's mostly chiropractors right now. As I mentioned, there's some MDs. But you can search on their website or you can search for the credentials, DIANM. And so these are going to be experts in diagnosis and management. Now, if you want to go see a chiropractor for a quick crack and to feel good, that's fine. But if you have a chronic problem that you need resolved, and you haven't been resolved for other people, I would seek out one of these specialists because they have some of the newest training, some of the newest information, and they might be able to apply that to your case. Just to give you another example of some important information is about the involvement of the brain in chronic pain. I've cured so many people of chronic pain syndrome or fibromyalgia, and that's typically considered an incurable lifelong disease once you get that diagnosis. but it's a combination of addressing the brain, the neuromusculoskeletal connection, brain training, tissue retraining, changing the adapting treatment for the patient visit to visit, frequent reassessments. I do hour-long sessions with patients. These aren't just quick 5-minute visits. I'm really putting into practice that it takes a lot of diagnosis, a lot of modifying the treatments to get this to work. And I've mentioned the brain and the nervous system. And in fact, I recommend, and you'll see a link somewhere in the video, for a lecture I gave in front of an audience about the nature of pain and what is pain. Because pain is part of a protection system. Pain is not proportional to damage. Pain can actually, your brain can create pain from the movement sensors. So if you're told, okay, if you move your shoulder, the bones are going to grind together and there's going to be damage, your brain is listening to that, and everybody's like, oh, movement equals damage? Okay, I better make it painful to train this dumb monkey not to move the shoulder anymore. And so you don't move the shoulder, your brain actually will forget how to move the shoulder. So you try to move the shoulder, but your muscles don't remember how, and it's discoordinated and you do hurt yourself. And the tissues will be deconditioned if you're not using tissues. Your body's like, well, why am I wasting resources maintaining these tissues? So your tissues will actually be weaker. So it's all that stuff together if you want to really address chronic pain and these trickier conditions. It's also medical doctors, chiropractors. Okay, what's the one diagnosis? And I found a lot of chronic pain. It's okay, how many conditions can this person have? Because you can have everything on top of each other. So it's these trickier things to diagnose and manage, which the specialty really helped me with, and I was able to help more patients. So again, I advise people, I suggest watching my video, and I recommend looking for these professionals, these DIANM professionals, neuromusculoskeletal medicine specialists, if you want someone who's particularly good at diagnosis and management. Okay, cheers.